All right, so after a day and a half of lecture, hopefully you're mostly dead inside now, so these 6 Dialysis Access lectures won't hurt one bit. All right, so I'm going to talk about anatomy. So the jugular vein, what you need to know about jugular vein anatomy is that it's behind the sternocleidomastoid muscle for all of its location except in one small spot. And some of you did the anatomy with me on Thursday, and so I had you resect the clavicular head of the sternocleidomastoid. So that gap between the sternal head and clavicular head is where you're going to identify the jugular vein. So in the old days, before we had ultrasounds everywhere, we had to kind of identify that spot, stick the needle in, aim for the nipple, and hope for the best. But now you have ultrasound, so it's really standard of care to use that. But you still want to know the landmarks of the jugular vein. So the jugular veins drain into the innominate veins, the brachiocephalic veins, they call them as well. The things to know about them are the orientation. The right innominate vein kind of straight shot right down the heart. That's one of the big reasons we prefer to do right-sided tunneled catheters. But the left one kind of zigzags across. And this is important because when you're doing a left-sided tunneled catheter, you want to take into account that anatomy. So what I try to teach my guys to do is put that wire all the way down in through the IVC. So through the SVC, through the right atrium, down the IVC. So you got a lot of pipe down there so that it'll track across it, because when you're putting those big sheaths in, you want to make sure it takes those turns and just doesn't go straight down and, you know, clean kill right through the innominate vein. So you put the wire all the way down, and there's another talk on catheters, so we're not going to get too into it, but it's important to know the anatomy there because of that zigzag. So you want to have a little backwards tension on your wire so the dilator will follow that course. All right, so what's this? It's an innominate vein occlusion. So then what's that? What? Yeah, well, I didn't block out FC. I know it's an SVC. What's the other thing? You are dead inside. Yes, that's a hemiazygos vein. Good. So the azygos vein can be your friend. It's not always your friend, but it can be your friend. So it's a rather inconsistent venous system that hypertrophies when there's SVC occlusion or SVC stenosis. Or innominate vein stenosis. And here you see somebody actually put a tunnel catheter all the way through the azygos system to get back into the SVC in the right atrium. And that's perfectly acceptable. What you don't want to do is sometimes you put the catheter in and have like a weird kind of tip. The tip looks like it's not quite going to the atrium, it's going off to the side. And that means it's in the azygos, and that in general will not work. All right, let's get pumped up for vein anatomy. So cephalic vein anatomy, most of you know, right? You can see it on most people. But the basilic vein, so here's a good example of cephalic vein. So right along the lateral forearm, all the way up the arm. Basilic vein anatomy is a little bit different. It's really very medial and posterior, and that's what makes it inconvenient in the forearm to use as a direct fistula. It's also useful, though, because phlebotomists and IV teams don't tend to stick it very much because of its location. So we transpose that over to the radial artery. As a word of advice, if you internet search bulging forearm veins, you go to a lot of questionable websites. So I hope you appreciate my efforts and will back me up if my wife does a browser search in the future. So anyway, cephalic vein, basilic vein, where do they meet? So there's something called the median cubital vein or the anacubital vein in the forearm. In Boston, we like to harvest arm vein to do bypasses because they didn't like me or something. So the anacubital vein was important because you can harvest the cephalic and basilic as one unit. It's important in terms of creating fistulas because you can often use that anacubital vein to do a direct fistula onto the artery, and it connects to the cephalic. But it's important to know where the connection is and whether it's patent or not. So the arteries, you guys all know this. Brachial artery goes into radial, ulnar, interosseous. But most of the exposures for some of the direct fistulas are done in the anacubital fossa. And so important to know where the brachial artery is. There's 2 veins usually paired to it. And where's the median nerve? Okay. The anatomy of the nerve is very important because that's the one structure you don't want to damage here and that you can accidentally. So also there's an aponeurosis that crosses the artery. People think that's the biceps tendon. It's not the tendon. You wouldn't cut the tendon, right? So there's an aponeurosis that you can cut that crosses over it. There's a good example of the aponeurosis. It crosses from the biceps over to the pronator. And here's a good example of the anatomy of the median nerve relative to the artery. So if you're going to get the artery up in the axilla, the nerve is actually medial to the artery, and then it crosses it somewhere in the upper arm and becomes, it's lateral, crosses and becomes medial in the antecubital fossa. So important to know that. This is really just to illustrate that the further up the artery you go, the more nerves you're going to encounter. So if you're getting it out in the axilla, you really have to be careful of the brachial plexus up there. Axillary artery becomes the brachial artery, gives off the subscapular artery, and then the circumflex humeral arteries, and kind of becomes the brachial artery there. Some interesting brachial artery anatomy is the deep brachial artery can actually become the radial in about 10% of the population. So the radial, some people call it a high takeoff of the radial, but usually what it is actually the deep brachial goes directly into the radial artery. And so if you're ever at the antecubital fossa and doing a direct fistula and the artery seems a bit small, what you might actually have is the deep brachial becoming the radial in the forearm. You can still do it off there, but it's usually less flow than if you have the true brachial artery. There's just another picture of that aponeurosis that can be cut to expose the artery. So the upper arm veins, the cephalic vein is the one we prefer to use in most cases. It's superficial, can be directly anastomosed to the artery. But the basilic vein is often bigger, but it's subfascial, right? So because it lies subfascial and because it lies very medial over the arm, we take it out and we transpose it. So what about the brachial veins? Well, the brachial veins usually join the basilic veins at some point to form the axillary vein. But this is very variable anatomy, and how many brachial veins you have and where they form to coalesce to form the axillary vein can be highly variable. So something that you want to pay attention to if you're going to do a transposition of the upper arm. So here, this is just a venogram we had done, and you see here's an unpaired brachial vein with a small basilic vein that goes in to form the axillary vein about the midpoint of the arm. So this anatomy is fairly common, but you will see a lot of variety. This is just some weird picture I found. I don't know what's going on there. Anyway, physiology. So every fistula steals, right? By definition, they have to steal because the resistance is so low that the blood flow is always going to go there preferentially over the arterioles and capillaries of the hand, right? So the body compensates for that seal by increasing the blood flow to that arm. So the side that has the access in actually has 5 to 10 times the amount of blood flow that the contralateral arm does. And that's why we don't see true physiologic steal in most people. The magnitude of flow that's produced in your fistula will be influenced by how close you put it to the heart. So the further up you go, or the more proximal you go, the more flow. The length of the anastomosis is important up to a point, and that point is the diameter of the artery you're coming off of. So if you have a 5 millimeter brachial artery, increasing your anastomosis past 5 millimeters will not increase the flow in the fistula. Linearly, anyway. It will to some degree, but not linearly. Blood pressure increases the flow in your axis, and also the size of the vein, right? The resistance in the vein will determine the flow. So usually the flow will go up about 50 to 100% in the first couple of weeks. You want it at least 350 cc's per minute. In Europe, they tolerate a much longer dialysis and lower flow on the machine. Here, money, so people crank up the flows. So I find that if the forearm axis isn't at least 600 to 700, and if the upper arm axis isn't at least 1,000 or a liter per minute, they'll usually send you back and say it doesn't work right. So after you put the fistula in, what happens to the patient? Their cardiac output goes up, their blood pressure comes down, their heart rate goes up, but overall their cardiac work goes up. So if you were going to make an anatomic model of producing congestive heart failure, this is one way to do it. So you do have to monitor people, especially people who have pre-existing congestive heart failure, because a large graft can produce it or exacerbate it. So we say the vein arterializes. What does that mean? It means it thickens, and that's caused by hypertrophy of the smooth muscle cells, elastin formation, collagen deposition, fibrous tissue. Basically, the vein just gets thicker. And then finally, the Branham sign. So this comes up often in lectures and conferences, but rarely in live. So what's the Branham sign? It's traditional. My fellow answers this and gets it wrong, so why don't we keep... what? Okay, and what else? Blood pressure goes up. Good. So increased blood pressure, decreased heart rate, and that's the Branham sign. So My wife and I and Eric apparently have had no formal training in dialysis access creation. After watching all of you Thursday, I think you can relate to having no formal training in anything. But it's important. This is a much more complicated thing than I first realized when I came out of practice, because the general surgery guys were doing it. But now, with all the interventions and things we do, it's become a very important part of everyone's practice. And that's why, you know, when we were fellows, 90% of us would have raised our hands that nobody did dialysis access where we trained. So I do think these lectures will be valuable to you. And I can tell you, as an aside, it's a very common cause of malpractice litigation as well. People make just, you know, mistakes with steel and things like that, and it's an automatic malpractice suit. So I do caution you to pay attention to these lectures. So, thanks, guys. No.